Good evening all. So when you see the impairment of vision, there are almost 19 million children are visually impaired and more common in developing countries. So you can understand the need for screening. Amblyopia being the most common cause, we need to, it's always better to screen the children early and detect amblyopia as early as possible to prevent visual impairment or blindness. So United States Preventive Services Task Force limits screening to children aged 3 to 5 years to detect amblyopia risk factors. So when you see the screening part, either it is school screening or pediatric eye screening. School screening in India, traditional method is to involve the teachers. So we always select one teacher per 250 to 300 students, and training is usually done at the base hospital, and screening takes almost 3 to 4 months. Usually these teachers are either physical education teachers or craft teachers who are not involved in children's day-to-day activity, or they have very less of connection with the children or the parents. And the ophthalmic team goes to the school for examining all the children. Vision is repeated. If necessary, refraction is done, not for all, only selected children. Dynamic and cycloplegic refraction if at all needed. Then glasses order are taken. Choice of glasses frames are not given to them. And children who need further treatment are referred to the base hospital. The disadvantages being burden on one teacher. They have to do screening on many children. It's a new, it's a new technique for them, so they take a longer time and more children. And as you all know, children doesn't cooperate even to us. So for teachers, it is even more difficult. And so there are a lot of false positives. Even sometimes I've heard teachers involve the older kids to screen the younger kids. Because they have a lot of work, they involve the older students to screen the younger kids. So because of the disconnect, the message from the ophthalmic team or the student having vision problem, it is not properly conveyed to the parents. And refraction is not done for all, so accommodative component we are missing. And no fancy frames. Nowadays, I think in all your practice you can understand children wants more choices. Whatever, whether it may be a dress or glasses or their food, they want choices, and the choice should be in their hand. And no ownership when the child is referred. So with all this, we have been, as an institute, we have been doing school screening with the traditional method for more than 2 decades. So when we saw a lot of negative things with the traditional method, we were always looking for a new method to make the negative points into positive. So when we actually went to Shankara Eye Hospital in Pamal for a visit, we saw a new program called Vanavil program, where they involved all the voluntary teachers and the volunteers to screen the children. So instead of 1 per 300, they almost had 5-6 per 300. So the entire process went on quickly. Within 2 weeks, they completed the 2 or 3 weeks, they completed the entire program. So with a slight change, what we thought was, why don't we involve all the class teachers instead of volunteers? So we selected the class teacher, we went to the school and we trained the teachers for screening. So each class teacher was screening only 40 to 50 children. And teachers completed the screening within 1 to 2 weeks, and rest of the process was same as traditional method, and the teachers were given the list of students whom they have to track, either for wearing glasses or referral children. So we compared around 40,000 plus children in both the groups. If you carefully see, the screen positive by the teachers were less in the all-class teacher model. It is only 9.7%. In the selected teacher group, it was more. It was 16%. So false positives were more. But when you see the true ocular pathology, which was 58.6 in all-class teacher model, but only 24.3% in selected teacher. So selected teachers were unnecessarily selecting. At the same time, they were missing the true pathology also. Again, when you see the compliance, when they were referred to the base hospital, almost 59.2 turned out to the base hospital in all-class teacher model, and in the selected group, only 12% turn out to the hospital. So you can understand how connected the class teacher is with the student or the parent. So this was published that time, and these two children had a family history of cataract. Both were almost near blind. Both had 1/60 in one eye, and one child had 2/60 and 3/60 in one eye. Both had bilateral cataract, almost absorbed. Their siblings, two more siblings also had cataract. Father lost vision because of congenital cataract. Mother was getting benefits from the government. Each child was earning 1,000 rupees for her. So she refused to bring the children to the hospital. Because of the teacher's initiative, they were brought to the hospital. Both were operated and they got useful vision. So we feel all-class teacher model is effectively to reduce the overload on the eye care staff. And class teachers play an important role in creating awareness even among the parents. And when we did the cost effectiveness study, almost 1/3 of a cost we could complete the school screening in all class teacher model. Coming to the next model, which was tried in Madurai Hospital with Orbis, it is called REACH project, where instead of teachers, the vision screeners, who are basically graduates who are trained to do vision checking. They used a vision screener with a 6:9 pocket screener. It had only 6:9 vision, this thing. It was Lagmar based chart. And they did the screening and everything was documented. And all children, all the selected children underwent autorefraction, retinoscopy and subjective refraction. In needed children, cycloplegic refraction was done. Here one more difference was there were a lot of choice of frames within the budget. And when they delivered the spectacles, the individual manager or that vision screener went to the school. They had an awareness class among the children who needed the glasses, and with that there were brochures given to them in detail about refractive error. So when you look at the complaints, initially they had some problem and they tried different methods. Then they could improve the complaints of wearing glasses up to 72%. Even the major study shows only 40 to 50% after 3 or 6 months. So definitely it shows when we change the strategies, even it may be a smaller change, will improve and make a remarkable difference in the child's vision or complaints to glasses. This was one model. Another model which I want to share with you is, for us, whenever we do school screening, our mind is how many children will have refractive error, how many glasses are going to get dispensed, and how many cataracts we are going to get. But there was a different screening done at Coimbatore, which was supported by USAID. Basically, they did screening for low vision, not only at the schools, at our vision centers, and they have trained key informants to find children with low vision in the villages. And with the Sarva Shiksha Abhiyan workers, they are central government employees who are involved in education, they have trained them. And school teachers who are involved in regular school screening, they have taught them how to select the students with low vision. And the primary care center, those are Anganwadi centers, even those teachers, they have trained them how to select children with low vision. So this was done at different centers. Different camps were done not only in the schools, at Anganwadi centers, in vision centers, and in special schools. You can see. And they were able to find many children with low vision, and low vision intervention was given to many children. This was a new method which was done at our hospital. Coming to the traditional pediatric eye screening, usually it is done at a common place like cataract camps. Advertisement is done locally. What I mean by pediatric eye screen is usually we aim for children, non-school going children under the age of 6 years. But most of the time what happens is, because of poor awareness, parents used to bring the school going children or older kids, because in their understanding, small children will not cooperate for vision screening. So they used to bring the older kids. So that method was a failure for us. So constantly we were looking for alternative method to screen these children, and a newer method which is less time consuming and less manpower needed, and we should cover a larger number of children. So we thought, why don't we use a photorefractors? Photorefractors use an infrared camera to capture the images, and it analyzes, and it in undilated pupil, and it also can assess the alignment of the eyes. It can be done by non-medical staff and simple to use. No cooperation from the child is needed, and there are humpty number of photo screeners, and we chose a plus optics S12 model because that point of time it was handheld. Only one model which was available was handheld, and the accuracy was well proven, and it was simpler to use, and we could document the data. So this is the model, and it can detect refractive error, pupil size, and the distance between both the pupil, and you can see the size, distance it can measure. It is given the refractive error, and age match criteria is feeded into the machine already. We have given our guidelines, we follow AAO guidelines, so we wanted that, and the manufacturer agreed, and he has incorporated that criteria. And see, either that machine gives pass or refer or inconclusive. Here it has referred, you can make out the child has got esotropia. So here it was not able to detect anything. We repeated 3 times, it says inconclusive. Then finally the child had cataract. This machine is not for detecting cataract. By default it refers cataract. This is a small video. With this machine we went to the preschools and the Anganwadi centers. The target was to screen 1 lakh children. So it's very simple. He's a non-clinical person, trained person. You can see how free he is holding the machine. The child is standing in the child is not scared, he is amused, and there is a target there. He was curiously looking at it. So the manufacturer promised it takes only 0.8 seconds, but when we do, there are a lot of like making the child stand, documentation, everything takes more time. It's almost 46 seconds, and for our surprise, girls took less time, boys took a longer time. And of course, younger children it took longer time and older kids lesser time. So you can see all the data, the child's name, address, age, everything you can save, and it can be downloaded in our computer. So with this, we did almost 1 lakh plus children. So you can see the past children are almost 77%. So you don't expect much of refractive error under the age of 6, more of squint and cataracts. But for surprise, almost 22% referred, but only 1/4 of the children came to the hospital In that, we could identify 41.87 refractive error, and the glasses were provided for 1,789. And we could get almost 18 cataracts, 71 squints, and ptosis was 26, and even we could get 1 retinoblastoma. So totally 62 surgeries we did among the children. So, but still the concern is too many children are referred. So with improving the light of the room and everything, we are actually becoming better. So when we compared the sensitivity in a focal group in them, we could see, like you can see, 82.27 sensitivity, and specificity was 86%. And to conclude about the screening for children, no single approach is helpful. It should be a multidisciplinary and a holistic approach. A non-class teacher model or a trained person can be used for vision screening. Refraction should be done for all selected students, and documentation is better. Choice of frames should be there to improve the compliance, and involving parents and students in the whole process is very, very important to improve the compliance, and including the low vision services without much effort can be done. And photo screener can be used in younger children in schools for the preschool children, because under 6 years teachers will not do the visions, and follow is a must for all the children. Thank you.